Please.
Okay, so I'll be discussing the carotid surgical techniques for symptomatic stenosis, mainly based on the 2017 guidelines with specific inputs where they differ in the newer guidelines from 2023 preprint edition. Intervention has been discussed very well by Dr. Anas, so I'll just move forward. One point I'd like to mention here is that in cases of tandem occlusions in patients who are going intracranial endovascular therapy for stroke, it is recommended in the 2023 guidelines that a synchronous carotid artery stenting may be considered in specific patients, depending on the risk criteria. In the 2017 guidelines, they had declared that there are no clear evidence, and this is a place for potential study. And in the newer guidelines, now they have said that in individualized patients, a synchronous stenting may be considered once they are doing intracranial endovascular. In cases of a free-floating thrombus in the carotid, therapeutic anticoagulation is recommended and thrombolysis is not recommended. In cases of recurrent symptoms after anticoagulation, a carotid artery stenting or endarterectomy may be recommended. So in carotid artery webs and chronic ocular ischemia syndrome, we can consider intervention if no other cause has been identified. So in patients who have more than a 50% stenosis with atrial fibrillation, according to the new guidelines, there are no definitive RCTs, and these patients had been excluded in the previous ECST and NASCET trials. So a pragmatic decision making is required. If there are multiple vascular territories in the brain which have undergone infarction or ischemia, they should be considered. The carotid stenosis should be considered asymptomatic, and they should be anticoagulated. A diagnosis of a carotid source can be made if there is an ipsilateral embolism on transcranial Doppler, there is an intraplaque hemorrhage in the ipsilateral plaque, and there is no evidence of left atrial appendage thrombus. So if a patient has been anticoagulated for cardioembolism, but then suffers a recurrent event in the territory ipsilateral to the carotid stenosis, it is reasonable to consider an intervention. And if investigations are neither diagnostic nor informative and more complex imaging is not available, a multidisciplinary team will have to make an empirical management decision in these scenarios. So a preoperative checklist which should be documented in each and every case is that what is the indication for surgery, if there are any atypical symptoms requiring further investigation, is the degree of stenosis appropriate for recommending endarterectomy, have the procedural risks been quoted to the patient, especially the procedural risks of the surgeon himself, not those which have been reported in the trials, whether the patient is receiving optimal best medical therapy, is a high carotid disease anticipated, whether there are any pre-existing cranial nerve lesions. For example, in cases of previous neck surgery, maybe you might need to do an ideal to confirm about a recurrent laryngeal nerve injury, and the operative site has been marked with a pen. So staged or synchronous bilateral interventions, bilateral symptomatic patients are very, very rare, and usually the symptomatic site is dealt with first. However, if you are considering a bilateral intervention, a bilateral carotid artery stenting, unilateral CEA with a contralateral stenting, or a stage CEA may be considered. So some recommendations have been left to the surgeon's discretion regards to anesthesia, whether general or local regional. Exposure may be antegrade or retrojugular. The incision may be transverse or longitudinal, and a shunting, choice of shunting, whether routine, never, or selective. These have been recommendations have been left to the surgical team's discretion. Carotid sinus blockade is not recommended routinely because it does not lead to decrease in episodes of hypotension, bradycardia. Protamine reversal of heparin should be considered to prevent neck hematoma requiring neck re-exploration. Regarding patching, routine patching is recommended, class 1 recommendation. PTFE or a bovine pericardial patch has produced the best results. However, in the newer guidelines, they have specially pointed out that vein patch blowout and infection incidence is very low. So it can be considered or it can be studied in the future. And eversion versus patch endarterectomy has been left to the surgeon's discretion. However, it has been declared that both eversion and patch have better results than simple primary closure. So regards to isolated coils, kinks, and loops of ICA, if the patient is asymptomatic, surgical correction is not recommended. However, if the patient is symptomatic, an intervention may be considered after a multidisciplinary team review. So intraoperative completion imaging, in the last guidelines 2017, they recommended an individualized or targeted strategy, but in the 2023 guidelines, They have said that completion imaging with angiography, duplex, or angioscopy should be considered. In high carotid lesions, perioperative planning is recommended. Strategies which can be employed is a nasotracheal intubation, which will close the mouth and give better access to the neck. Subluxation of the TM joint may be done, and for that we will be needing help from our maxillofacial surgeons. And extending the incision anterior to the ear and mobilizing the superficial parotid lobe. Obviously, we might need our head and neck surgeons for help for that, but these are the strategies which can be employed. So in regards to wound drainage, selective drainage is recommended according to the newer guidelines. And they have said that in RCTs, there is no considerable difference in reintervention rates. Whether the patient should go to post-op ward, HD or ICU. So it is recommended that 3 to 6 hours of close neurological intra-arterial BP monitoring should be done in the recovery room. Up to 40% of patients have episodes of hypertension in the early post-operative period and can be managed. If there are no further episodes of hypertension, the patients can be if the patient require ongoing intravenous hypertension. So, with regards to infection, carotid stent explantation, so it is PTFE. And regards to the surgical technique and end-to-end or end-to-side anastomosis, both can be done. So the extracranial to intracranial bypass, classically it was done with a superficial temporal artery to an ipsilateral middle cerebral artery bypass. However, no benefit has been conferred over best medical therapy, and it is not recommended. So these are my references from the 2017 and the 2022-23 guidelines. And thank you so much. If there are any questions, I'd love to answer them.
Thank you, Sabi. That was very excellent and very kind of you actually updating us with the current guidelines. If there are any questions, their comments, they can be placed in the chat box. One of the comments which we are getting from Dr. Varion, which is particularly with Dr. Anas. I hope he is with us. He presented recommendation for DAPT prior to carotid endarterectomy. Previous guideline has been recommending monotherapy only for carotid endarterectomy perioperative period. So is there any new change in the guidelines? So is Dr. Anas with us? Then we can go to Sabi's points, which are very relevant.
I think Anas will answer this question shortly.
Okay. So
he'll share his slide for that.
Yeah.
And that was a very nice activity, and all of our fellows have done very well. Thank you, Imran, Saqib, Ans, and Sabi for making these presentations, and thank you, Zia, for arranging that.
And that is very great of you. This has been a great, wonderful experience working together in collaboration. And there was a wonderful journal club which we had, and this was a great activity of lecture series which we have started, and that has updated the knowledge. I hope that will continue. If we go, I invite other centers, especially if Dr. Briam is with us, Dr. Fad is with us with Trauma Center, and also Dr. Umar Ehsan from Shifa, that they can join, and we can go for the next month for that, and these things. And Dr. Anas is with us with these his slide. Yes. Yes, free of the compare. Assessing the recurrent store 3%. That is great. There is a randomized trial which is observational, and that has shown that there is less chances of perioperative stroke, which is there, and that decreases the odds ratio. Coming to Sabib presentation, I like the recommendation which is there. One is actually using the patch, and they are rightly saying that the patch should be used not the vein, because it has more chances of the blowout as compared to other prosthetic graft, and primary closure is not recommended. Secondly, the change which I see is that doing of completion angiogram, which was not there, and this is rightly said, because at the end of carotid endarterectomy, there's about 7 to 8% of the persons who have a technical problem, either an intimal flap or some in situ thrombus, which can be left. And doing an intraoperative angiogram or completion study is very great. If it is not available, doing a simple duplex scan can also show in situ thrombosis, and it can show the intimal flap. And then a very good slide has been told about the kinks, that if normally when endarterectomy has been performed, there is some redundancy or there is a kinking there. So if the kink is not 90 degree, it can be left. But if it is 90 degree, it has to be corrected. Although it varies from surgeon to surgeon how to correct that kink. One way of correcting the kink, if you are expecting, is to start with an eversion endarterectomy and then actually close it up. Second way is actually to do a resection of that part and to do end-to-end anastomosis, that is internal carotid artery. Third part is actually transposition of third is actually resection of the segment of the common carotid artery. Instead of doing that, removing that kink, that elongates that segment and actually correct it up. And it is technically much easier as compared to that. And then rightly said about the shunt, that selective, it depends upon the discretion of the surgeon. If it is done under local anesthesia, definitely 10% of the people need shunt. And if it under general anesthesia, some people are using routine shunt and some are using selective shunt. So, Sabi, what is the current recommendation for using shunt, or it is up to the discretion of the surgeon?
Sir, it is up to the discretion of the surgeon whether they are routine shunters, selective, or never shunters. Okay. It has been left completely up to the discretion.
Yeah, that makes sense, because how a person is trained, how it is experienced, that is there. We have been switched from a routine shunting to a selective shunting. We are using the stump pressure and we are checking it up. I wonder what is Dr. Elias Spector, Dr. SN practices currently. Are you using shunt routinely? Are you using selective one?
Yeah, thank you. Yeah, I use shunt only when we have to do it under general anesthesia, okay, or if there is a complete occlusion on the contralateral side.
Oh, good. So are you doing under local and regional anesthesia?
Yes, we almost always do under regional anesthesia.
And what is the ratio? What particular patient you are selecting for general anesthesia, and what particular patient are under the local anesthesia?
Any patient which comes under a reasonable age, like below 80, and we think that person could be cooperative enough for the anesthesia to go on, and we let the anesthesia team to talk to the patient as well, and if they recommend that this patient could be cooperative enough, so we proceed with the regional anesthesia. And now I think we have done only 3 or 4 patients only under general anesthesia. Okay. Most of our patients are under regional.
Okay, so that I love to listen to the comments of Dr. Hassan before he leaves.
Thank you, Zia. For shunting, we use shunt only under general anesthesia. And for local anesthesia, we don't use shunt routinely, but only use it if the patient's condition changes or demands that. If the patient is very frail and looks like that he or she may not cooperate, then we do the procedure under general anesthesia and use shunt.
Okay, and you do not go for selective, but routinely shunt. Yeah. Okay, so with that, I suppose I can actually close the session. I thank you, every one of you, for actually participating in it. That has been wonderful experience. I am especially thankful to Dr. Ehsan and the fellows, Dr. Imran, Dr. Saqib, Dr. Anas, and Dr. Sabi. They were wonderful presentations, and I hope to see them again in our this forum. And thank you, Dr. Ilyas, Dr. Iqbal, Dr. Nadeem, and Dr. Ghulam Ali and Dr. Varyam for participating in all the fellows which are with us, Dr. Khalil and Dr. Fahad and Dr. Umar Haslas. So hope we will meet after 2 weeks. Thank you for participating. Assalamu alaikum.
Thank you, everybody.
No.